Coming up today, cancer can't break a brother's bond. Their story and one man's path to survivorship after a rare cancer diagnosis. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. It's a rare type of non-Hodgkin's lymphoma that's often mistaken for a rash or a sunburn. For years, that's what Jim Gordon thought it was. Turns out it was cutaneous T-cell lymphoma, a cancer that starts in the skin and in rare cases takes multiple treatment paths to control. For Jim, it would take that and some big help from his little brother.
Two brothers, 8 years apart, grew up in different phases of life.
I idolized him because he's a big older brother.
But always shared a deep bond.
You never know, Dan was a slacker.
That connection became life-saving when Jim Gordon faced a rare cancer diagnosis.
We thought it was a sunburn, and I went to a dermatologist, and she gave me some creams and lotions to take care of it. And then it came back, and she said, well, this shouldn't come back. So they did a little biopsy.
It was 2016 when Jim was diagnosed with cutaneous T-cell lymphoma, or CTCL.
It really didn't register at first. I don't know if I wasn't ready to hear it or what.
Jim began UV light therapy, much like a tanning booth without the harmful UV rays, and later moved to photopheresis, where blood is treated with light and then returned to the body. When his doctor suggested a bone marrow transplant, Jim turned to his younger brother.
He said, I love you, and you're my brother, and I'll do whatever it takes.
I still do.
Yeah, thanks.
Testing confirmed Dan was a match. Of course, he had a few questions.
It was more like, well, is it going to hurt? But then they explained it's a little bit different process now, where they do it distally. They shoot you with some medication to help increase the amount of bone marrow in your blood system. With that explanation, it was, you know, I can do this.
Doctors explained that CTCL is rare, and it's even rarer for it to progress to the point of needing a bone marrow transplant.
One of the doctors used to say to me, we do 300 bone marrow transplants a year at KU Med and one for CTCL. So I won the lottery, I guess.
After the 2023 transplant came new challenges, but Jim's care team helped him stay positive.
It's unlike any place I've ever been, and with that, I've found everybody very willing to stop and talk, and so you're not just another patient.
Now retired after decades as a Presbyterian minister, Jim reflects on life, family, and faith.
Yeah, I feel good and feel amazed at how much better I feel than I did.
And Dan is simply grateful.
You do what you can for family, and I mean, I'm glad he's still around.
Yeah, most of the time.
Most of the time.
Yes, we are very glad he is still around. Jim is joining us here live in our studio, 2.5 years out from his bone marrow transplant. So glad to have you with us.
It's good to be with you.
Yes, it really is. We're also joined by two members of your care team that helped guide you through all of this ordeal. Dr. Sunil Abhyankar, hematologist and transplant specialist, and Ellen Klostermeyer, post-transplant nurse here at the health system and the Cancer Center. Glad to have both of you here with us.
Nice to be here.
Nice to have you. And Jim, you said you both were like, it's so nice to see you outside from underneath masks.
Yeah, I've never seen Ellen without a mask before. Which, yeah,
Here I am.
to her. Yeah.
Right? Well, yeah, because you're used to seeing her and staying safe behind masks and well protected.
Right. Oh, yeah.
And
That's right.
yeah, so there she is.
There she is.
In all
I
her
know.
glory, looking
Good to meet
beautiful
you.
today.
Good to meet you.
Yes, you too, Jim. Nice to meet you.
So let's start, Jim. You're 2.5 years post-transplant. Just how are you feeling today compared to back then?
I feel good. I feel a lot more energy than I had before the transplant and in the year of recovery after the transplant. I've never had any pain to speak of, mostly fatigue, but that's par for the course. So
yeah,
I feel good.
Doing good. Well, we like to hear that. Dr. Abhyankar, so CTCL often looks like eczema or a sunburn. That sounds like pretty manageable, something that we could work through. But what would prompt someone to go seek out a biopsy for that?
I think if someone has eczema or a rash, especially that is in the covered part of our body, and it's not getting better with topical treatments, then that would be a good time to see the dermatologist, the skin doctor.
So this started in the skin. So my question was, when I met Jim, was did that mean that he had a skin cancer, a type of skin cancer?
No, it's actually lymphoma.
Okay.
So it's a blood cancer, but for some reason, these cancer cells have a predisposition to get attracted to the skin. So these cells originate from our lymph nodes and our blood, and then they migrate to the skin, and they cause irritation of the skin, and itching is a main, very strong symptom of this condition, and in most of the cases it stays in that fashion, controlled with topical medications and things like that.
So that was the initial treatment path. So that was like one of 3, correct? So talk us through that. He goes in, they give him these lotions.
Yeah, so usually you end up seeing the dermatologist, and all the treatments are topical based and creams, mostly steroid creams. There's also a vitamin A derivative that's as a cream, and then UV light, the kind that is not too damaging to the skin, so UVB light that some of patients are able to do at home. They have a kind of a machine at home, and they lay under the light. I don't remember if you had one at home too.
I did,
yeah.
after a while.
Yeah.
What was that like, doing the UV light treatment?
It was a lot easier at home. It was just 5 minutes as compared to driving down here, several times a week.
So why didn't that work?
So in some situations, the disease just keeps progressing, and because we don't really have a cure for this condition, even when it's limited to the skin, we just manage it symptom-wise and prevent it from spreading, but there's no actual cure for it. In many patients that can go on for several years with topical treatments, UV treatments. And then at some point those stop to work, and also we may sometimes then notice that we detect these cells, the cancer cells, now in the blood.
But still, is it true that I understand it to be very rare for someone with this type of cancer to then ultimately need a bone marrow transplant?
Exactly, you're absolutely correct. And one of the reasons for that is most of the time when people are diagnosed with this condition is usually we are older, like in the 70s. Usually, and high 60s, etc. So and then at that age, it's difficult to proceed to a bone marrow transplant. And one of the reasons that we were able to proceed to a transplant in Jim's situation was because he was young, much young, to get this condition. And of course, fortunately, he also had a brother who was a match. Yeah.
Well, he said he won the lottery. That was quite a positive way of looking at all of this, that he won the lottery.
Millions that I didn't receive. But
You got a bone marrow transplant instead of the millions.
That's right.
Good for you. We've got a little bit of video kind of showing how this all works, but this is not Jim getting a transplant here, but another patient undergoing a similar procedure. How do you determine when CTCL has progressed enough that a transplant becomes the best option and a path to possibly getting somebody into a type of remission state?
That's right. Well, we want it to be a cure, obviously, but getting to remission is the first part. So there could be several things that can happen. Firstly, the first common way would be that the lymphoma that involves the skin just keeps progressing and the treatments don't work, and it still stays in the skin. It doesn't go to the blood or maybe to the lymph nodes, but isn't causing the classic lymphoma symptoms, that people with other types of lymphoma get. So by the way, the CTCL is a type of non-Hodgkin lymphoma, and it only accounts for about 3% of cases of non-Hodgkin lymphoma. So it's a very rare skin lymphoma. So when somebody's skin starts flaking and none of the treatments are controlling it, it gets very advanced, and if they are at a suitable age and they have an appropriate donor, then we can look at doing a transplant. And then in other situations, these cells that are in the skin, they can transform and become what is called a large cell lymphoma, which is what happened with one of your biopsies, showing that the cells were now behaving like a large cell lymphoma. And when they do that, it generally tends to be more aggressive, and that's when topical treatments or photophoresis does not work. And then we have to look at intravenous cancer type infusions, sometimes chemotherapy, and those treatments you can only keep doing for so many times. So that's the point at which we then start saying, should we take this person to a donor transplant?
So, Jim, what do you remember about that conversation? We're now at this point where you're going to need a transplant.
Well, you can see Dr. Abiyankar has a very easy way of making difficult things easy to understand. And I also learned that he says, well, let's try this, or we'll think about this because we might need to do it later. And he's thinking, we'll probably need to do it later. And he said very early on, let's type you, cross-type you for a transplant in case we need to someday, down the road. And so when it came time to do it, I was ready to hear it. And so, that's one of the things I appreciated greatly about Ellen and Dr. Abiyankar is their compassion and leading me through this process. I've never been through before, but is every day at work for them.
Yeah, we hear lots of good things about Ellen and Dr. A. And how great was it that he had a brother that was 8-9 years younger?
Exactly.
That very rarely happens that you have someone who's that much younger, and that must have really worked in his favor, right?
Absolutely, it did. Absolutely, it did. So that was very lucky, the 25% chance that your sibling would match with you, and then to have a younger sibling match with you. Young donors have more flexible, pliable lymphocytes, and so that's to advantage because less likely to cause complications. Yeah.
And Dan's doing well, your donor?
Yeah, he's doing very well. Yeah.
Good. He was ready to go. It's just what you do for brothers, right?
Yeah, that's right. I thought he'd need some time to think about it, but he said, I love you and we'll do this.
Yeah, that was great. Such a great guy. Ellen, what are those first weeks after a transplant? Because you're a post-transplant, very specific, nursing specialty, because you're taking care of these patients in these very precious moments after this transplant. What do those days look like for a patient like Jim?
Yeah, usually the first couple of weeks post-transplant are in the hospital, and in Jim's case they were as well. You got out pretty early though, like around
3 total weeks.
Okay,
yeah. 4 and 2 weeks after,
including the prep chemo.
Yeah. Right.
So he came out pretty early, but regardless of how early you come out of the hospital, we're looking at 100 days of isolation, which is you and your caregiver, which was your wife, Marcia. So just Jim and Marcia for 100 days, isolating themselves from family and friends, but also coming to clinic 2 to 3 times a week, blood draws, infusions when you need it, all that good stuff.
And so seeing you behind that mask,
right.
Well protected.
Yes, lots of time in clinic, yeah.
For sure. What are the biggest day-to-day challenges? I'll ask Jim, but what do you hear often from other patients too?
I think the isolation is the hardest part. That's a long, 3 months is a long time to be away from your family, especially if you have children and grandkids. So I know that was a big challenge for Jim and for a lot of our patients, but it's a test to be with one person for 3 months. So I think if you can make it out alive, you're in good shape.
Yeah. Well, I bet when they see you, they're sure happy. You're like a new face. They're like, okay, we'll take it.
Clinic sounds like a chore, but sometimes I think if I was in that situation, I'd like the interaction.
For sure, Jim. Was it kind of like that for you?
Yeah, absolutely. We've gotten to know all the doctors and nurses at the clinic, and who has a new dog, and who's pregnant, who's going to be married, and so that was our social life.
Yeah, it was like the little soap opera of your day. You just go and find out what's going on with the gals at clinic.
I know. We go 3 or 4 times a week. I think the first period of time.
Gear up and go to clinic and get your fill. What was the toughest part, though, for you post-transplant? You're doing well today, but what were those tough days like?
Well, being with my wife alone for 3 months, it was a 3-month honeymoon. What can I say? Actually, she's much more detail-oriented and clean than I am, and so it was like waking up in a minefield every day. These things that could potentially, when I had no immune system, caused me to be sick or even worse. So food and all preparation and all these things are very meticulous, and she was very good at that. But it was a challenge. And once we got kept working together on it. It became a shared project.
Yeah, I bet. But I
Yeah.
mean, being a caretaker of someone who
It's a big commitment.
It is a big commitment.
And they wouldn't do the transplant without her signing to be my 24-hour caregiver.
Yeah, you've got to have
Yeah.
buy-in from someone at home
Yeah.
to really go through
Yeah.
it, and you got to really have that emotional support from people on the other side, right, Ellen?
Oh, yeah.
Mhm.
Oh, yeah.
It's
Yeah,
important.
absolutely.
It's important. We were talking about Dan, Dr. Abiyankar, Jim's brother, but why are siblings often the strongest match? And if you don't have a sibling, where do you go?
So a very good question. So 25% of the time, a sibling could be a perfect match, and perfect match means you inherited the same genes from mom and dad, and so that's why. But it's not like a twin, so you're not identical in that sense. You still have some differences, like different characteristics and different blood type maybe, but there are the major part of the immune system, the HLA and the immune system, you are matching. So that portends a very good outcome with the transplant. So when transplant was first being investigated, people did twin transplant because it was the best match. But they found out that the twin donor has the same immune system as the patient does, and so it didn't help the leukemia or the lymphoma. It relapsed. And then subsequently HLA tissue typing was discovered, and then now we know that the best possible donor would be a sibling, brother or sister, who is 100% HLA matched with the patient.
So now I met Dan's wife as well. I met Dan and Jim and both of their wives, and Dan's wife was like, "Oh, great! Now there's two Dans walking around." Is that true? Is it like having two Dans now in the world?
I guess in the blood, yes.
In the blood, okay. So kind of like that.
He likes to fish, and I have this great desire to fish now. I've never
Do you
fished
really?
in my life.
For
No.
real?
Yeah.
Is that okay? Okay. Those are questions I would have.
Yeah.
Okay.
But it is interesting. You can pass allergies, So
Pass allergies.
Yeah.
Okay. But
And,
not fishing.
not fishing.
Okay.
Unless that's an allergy of some kind.
But you could maybe blame some weird habits you have
Oh,
now.
yeah, it's all Dan's fault.
I would blame everything on Dan from now on.
You're right. That's right.
Okay, that's my new advice.
Yeah.
I do want to talk about some symptoms, though, because that's something that we talked with Jim about. I want to walk through some of these symptoms of CTCL. Persistent rash, because let's go through these, because then we want people who are watching to know what to look for and when to go see a doctor. A rash that doesn't respond to these typical treatments. How does it look different? Does it respond? If you're going to go get over-the-counter medications, where do you see these rashes, Dr. A? Where would you see them on the body? Are they just randomly showing up, or is there a specific part of the body to look for them?
Yeah, they usually show up on the parts of the body that are covered with clothing. So, like in the groin area, but also under it could be the forearm that is covered and not exposed to the light. So that's where it kind of starts, and often that may be a reason why people don't want to say that they have a rash and stuff like that, and maybe
because there might be in a weird spot.
Yeah, might be in a weird spot. And then it's also known that the average time it takes for a person to then, yes, I had that rash 4 years back. It's between 4 and 6 years before actually a person then realize, this is, not a simple rash or eczema, but it is something more serious. And that's how long it even takes sometimes the medical establishment to get that diagnosis.
Right,
Yeah.
right. Especially if you're putting something on it, it goes
Right.
away, keeps coming back. Another symptom might be like a raised lump. When you say a raised lump, how raised, how big, what might that look like, and where might that be?
Yeah, so that would be a little unusual manifestation, but it can happen.
Okay.
So the CTCL goes this in stages, and one of the stages of the CTCL is having lumps or tumors in
Okay.
the skin. And unfortunately, in some patients, it may present like that with tumors in the skin. And these tumors usually can be very obvious. This is a bump on my skin, and it is usually it is like a solid bump. It's not like a liquid, like a cyst or anything like that. But sometimes it can be under the skin, and it can then be felt as a bump under the skin.
What about itching?
Itching is a very characteristic hallmark of CTCL.
Okay.
So along with the rash, there is itching. And when the rash gets generalized, then it causes itching of the whole body. That can be
Any other unusual symptoms to look out for or to go see a doctor for?
Those are the main ones, yeah.
Jim, do those sound pretty familiar to you?
Yeah. I initially didn't have a lot of rashes, and I had this weird sunburn on my hands, and it came back, and that's how they did the biopsy and discovered it. But near the end, my skin was very ragged, I guess, very fragile, and the itching was unlike anything I've ever experienced before. It's like scratching didn't help, but it was too deep to get at. It was just constant. Yeah.
You're like, I got to get in to see somebody.
Yeah, right. Oh, yeah.
It's time. All right, if you have questions, use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Dr. Abiancar, how does photopheresis work? Why is it a common bridge therapy before a transplant?
So photopheresis, so as I mentioned, some patients with CTCL, like in Jim's instance, also these lymphoma cells circulate in the blood. So the thought was, if UV light helps the skin, would UV light also help get rid of these cells in the blood? So this photopheresis was first devised at Yale, in Connecticut. And the basic principle of photopheresis is to isolate the white blood cells from our blood and expose the white blood cells to ultraviolet light. And while that is being done, you add a medicine that's called a photosensitizer that then makes the cells more sensitive to ultraviolet light. And by doing so and exposing our white blood cells to UV light inside this machine, the cells get damaged, the lymphocytes get damaged, and these damaged lymphocytes then circulate back into the blood, and they cause a reaction of the immune system. And that ultimately is how photopheresis works.
Ellen, what lifestyle changes help protect the immune system in the second and third year post-transplant?
Typically around the second and third year, we're a little bit more lax on the things that you're able to do. You're able to be around your family more frequently, but there's always an element of like immunosuppression to what's going on with these patients. So we're supportive for how aggressive a patient wants to be. If they want to stay careful, we help them find ways to be careful around others. And if they want to be with their families and be out doing stuff back to normal, we try to help them find ways to make that safe. But we monitor the immune system closely. You get checked at minimum every year. So we're watching that closely, and then we can kind of give recommendations based on what all that looks like.
Jim, how did your faith and background as a minister shape the way you approached treatment and recovery?
Well, I was a minister for 36 years, and so I'm not surprised anymore by things that happen to people. I mean, life is hard, but God is good, and it's finding the balance of those two things. Life is hard as God is good. I mean, it's by whatever name we call God, but as Christians, particularly this time of year, celebrating that and the birth of Jesus, who was born homeless and became a refugee, born in a stable, yet God worked through him in a way that no one has ever seen.
Well, speaking of being a minister, you married your little brother off. And here's some photos I want to show. So I guess he was returning the favor by giving you his immune system all these years later. I think it's only fair that you married him all these years ago that he did return the favor. What a special moment to be married off by your older brother. Just what does he mean to you? I mean, back then, obviously, so much, but just now, so few people get to share a moment like this.
Yeah, I think I'm eternally grateful for what he did. And that's a picture of his son Michael, who was married a couple of years ago, and his youngest daughter Grace is going to be married next year, and I hope to be a part of that as well. But yeah, we were obviously different ages. I was 18 going off to college. He was 10, doing whatever he did, in third or fourth grade, and so it's only later in life, and particularly taking care of our mom, who's in memory care, and that's brought us closer together.
Well, it's just fantastic. We're just so glad that you're doing well. Ellen, what signs tell you that a patient's really turning the corner when they've gone through a big experience like this. You know, we're looking at somebody who's 2.5 years out and just doing well, and just so grateful to be living life. But what tells you that someone's doing good?
I think that less clinic visits is an obvious
You see
way
them
to
less
know.
and less, so yeah, that's a good sign.
Yeah, when we get to the end of the visit,
Not that I don't like them.
no, I understand. And Dr. A says, we'll see you in a couple months. You know, that's a great sign.
Yes.
But I think hearing about all the stuff that Jim has going on and on other patients' travel, like getting to hear about those types of things, being around your family for the holidays, I think it is an indicator to us that you're doing well.
Let's get to some questions from our viewers this morning. And Gene has a really good question. I'm glad he's asking this because we touched on this earlier. Would it be possible to have a transplant if you lived alone? And how do we help those patients?
That would be a tough situation to be in because going through the stem cell transplant, so there are two kinds of transplant. The one is autologous stem cell transplant. And yes, autologous stem cell transplant can be done for if somebody, let's say, doesn't have any caregivers. But that will involve mainly admitting to the hospital for the duration of the transplant. Now, with the kind of transplant that Jim went through, which is a donor transplant, because the process of recovery takes many months afterwards, you need a caregiver support.
Okay.
So it could be it doesn't have to be one person. People, friends, or whoever.
Reach out.
Yeah,
Reach out
reach
to your
out.
circle of
Exactly.
friends, your community,
Exactly.
and
Yeah,
band them together and make it work.
and then you can have a patchwork of like people who can help
Yes.
in the first 100 days of the transplant.
Just that 100 days.
Yes, right.
Get through that 100 days, right?
Right.
Nathaniel has a question. How long do you have to wait post-transplant to know if the bone marrow transplant is successful?
So depending upon how we do the transplant, like in Jim's situation, we checked in his blood from day 30 onwards, so a month after transplant. We checked to see whose DNA this was, and we kept monitoring that throughout the transplant. So even at day 30, you will find that the majority of the blood cells are the donor cells. And then over time, we want those cells to be 100% donor. So as early as 30 days after transplant, the cells that we see in the blood can be from the donor. And then long term, we keep checking that once a year till about 4 or 5 years after transplant, because beyond that, it's unlikely that that's going to change. Yeah.
Jeff wants to know, if someone doesn't have a family member that's a match, how long does it usually take to find a match?
You see, so nowadays with the way we do the transplant, we work on finding a donor simultaneously. So we type the family members, we type children, younger children, or we type nephews and nieces, and then of course the donor registry. And we have like 25 million people on the donor registry who are volunteering to donate their bone marrow stem cells. So all this process occurs simultaneously, and then and it takes 3 weeks or so to find all the information, get all the information from the family member typing, from the unrelated donor registry, and then we have this big meeting every Tuesday, multidisciplinary meeting, where we kind of go through the options, what donor option does the person have, and based on the donor's age, the donor sex, the blood type, and then a virus called CMV exposure, we then determine what is the best donor for that particular person.
Yeah, I always call it like you have this like mission control
Yes.
upstairs on the floor where it's like everybody gets together. And you have this big team working, and it's not like, oh, option A didn't work, so let's hustle and try to find option B and then option C. Yeah. You already have these options laid out way in advance, so that when option A, B, or C doesn't work, you already have all these options working way ahead of time, right, Doc?
Exactly. Yeah.
And it's really great to see, so you're ready to go. I have one more question, and I think this is important because we went over those rashes and the itching, but Brad is asking, if that rash does not go away, truly, how long should someone wait before they go to a dermatologist or seek a doctor?
Yeah, if the rash is not going away and you try topical steroids and other topical things, then you should not wait. Within a week or two, you should go and see even your primary care doctor.
Yeah, because anymore you could like take pictures of it, send it through my chart, just get some sort of opinion, get that conversation rolling. Okay, Ellen, what's the big takeaway from our conversation today? What do you want people to know?
Oh, that Jim is doing incredibly, that transplant's possible if you have a lot of support behind you, and Jim really did, so we're just happy that he's here and doing so well.
Well, thanks for all the work you do post-transplant for our patients. Jim, what's the big takeaway from your story? What do you want folks to know?
I think what I didn't realize until I was into it is that bone marrow transplant is a process. I mean, chemotherapy, radiation to prepare for the transplant itself, and isolation, hospitalization, isolation for months. So it's a marathon, not a sprint. And the other thing is you can't do it alone. Having a great care team is part of it, having a great support network is another part of it, but just admitting that this is not something I can do by myself was humbling but important.
Well, thank you so much for sharing your story. We're just so glad you're doing well. Dr. Abiyankar, what's the big takeaway today?
The big takeaway is having a positive attitude like Jim has had throughout. I feel all of us get inspiration from many of the patients who go through this, and admiring your strength and courage, not just physical strength, mental strength. And when you have complications and going through that, and having a good team who can take care of you, not just the medical part of things, but your financial piece, the social piece, the psychological piece. And we're fortunate that we have all those elements here to make the whole team go through transplant.
Thank you to all of you for being here with us today. Thanks to our guests. Thanks to our viewers for being with us today. And here's what we're working on for tomorrow. A high school tackle nearly ended James McGinnis's life in 2014. Given less than a 7% chance of survival, he relearned every basic skill and built a new life grounded in determination, family support, and expert rehabilitation. Join us tomorrow as he shares his medical triumphs.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.